All right, so this is a quick overview my colleague Andrew and I will do about some GP scenarios that you're going to see in the clinic that are related somewhat to the brain or the spine. And we'll just mix it all up. We've both got some slides on each topic, and I guess we can keep it very informal. You're welcome to ask questions. Bruce texted me this morning, Bruce Errol, obviously, the big professor, texted me this morning just reminding me to talk about the 1-minute neuro exam to make life easy. So I guess most of this is to help you in your daily practice in terms of making life easier, finding tips and tricks in terms of the neuro exam, or spotting when something is a problem and knowing when to send someone in either urgently or when to send someone in more electively. And getting through that day of constant, probably 20 or 30% of patients you see have some sort of element of pain. We'll talk about different parts of pain today. Andrew's going to start by talking about trigeminal neuralgia, which I'm sure you've heard me talk about it before, but a slightly different perspective perhaps.
I always get a little bit scared when someone talks about a 1-minute neuro exam. It makes me think we should do 1-minute CT scans, 1-minute GP consultation. Anyway, so we're going to talk about the various bits and pieces. It's interesting, trigeminal neuralgia was one of the topics that we talked about, and I've just been in Australia marking the exams for the intermediate for neurosurgical trainees. And the topic that I was marking yesterday was trigeminal neuralgia. So it gave me the opportunity to brush up on what I didn't know. And so that I can try and sound as though I know what I'm talking about now. So trigeminal neuralgia has been around for a long time. It's been written about in literature. There are some fantastic paintings of the torment that people suffer. And it's got the term tic douloureux. And prior to about the 1920s, it was associated with a high suicide rate because it is a torturous, horrible condition. And certainly the people that I see with true trigeminal neuralgia, absolutely miserable, and you want to do anything you can to help them. The problem with it, it's actually difficult to manage. So the first instance is how do you work out what it is? Because as you start investigating facial pains, most people during their lives will get some form of facial pain. So, anyone know what that is? It's my birthday this month. That's the Libra sign. But it also is slightly scary and torturous. So trigeminal neuralgia is a shooting lancinating. So the lovely term that people use is this lancinating, getting a lance, getting stabbed in the face. It's usually in V2, sometimes in V3, rarely in V1. And if that's the one thing that I can get through, it's a shooting pain that's short-lived, that goes into the upper jaw, upper teeth, sometimes into lower face. Now, the longer you've had it, the more diffuse it becomes, and it's triggered. So this is I don't know how to do it now. This is the best slide I could find. But if you whiz round it, this is what trigeminal neuralgia is. It's shooting and sharp. It's terrifying and exhausting. It's unbearable. It's usually in the second and third division. Most are unilateral. So if you've got bilateral facial pain, you can get it with multiple sclerosis, but it's usually unilateral. It lasts seconds. There is usually no after pain or only a dull after pain. You get periods where it's terrible for a few months and then there's some remission. It's triggered by light touch, wind, eating, brushing teeth. And the one that really gives it away to me is people won't put makeup or lipstick on. And they'll put lipstick on, I've got one lady, puts lipstick on one side of her lips, but she won't dare touch the lips on the other side. And people, it is a scary thing. It's relieved by drugs, and I'll briefly mention that. Sometimes sleep. I can do this. There are divisions. This is mainly for neurosurgeons to argue about who should be treated in which way, but there is a classification which is constantly evolving. The one that we've discussed is classical trigeminal neuralgia that responds to the treatments we're going to talk about. Type 2 trigeminal neuralgia tends to have a more aching, throbbing, burning component, same distribution, less effective in some of the treatments. And then we talk about there's neuropathic pain, there's secondary pain relating to things like tumours, and that can be in a different distribution, not the classical trigeminal neuralgia. And of course, things like post-herpetic pain. Just as a reminder of what your branches of trigeminal are, and I thought it was interesting because what's inside your mouth is sometimes you forget is also trigeminally supplied, including your teeth. And everyone gets teeth. Well, I do. I spend a lot of money supporting my dentist's ways. So tip of the nose, eye, V1, V2. So ophthalmic goes down your nose. Maxillary to upper jaw, mandibular, lower jaw. Apex of chin not supplied by trigeminal nerve. So the pathogenesis, I put this up because Patrick will tell you more about this, but I have no idea. People don't know. There's a concept based really on the effectiveness of some of the treatment as to what exactly is going on. But the current thoughts are central demyelination within the nerve root entry zone and reinforcing electrical excitability, the ignition hypothesis. Anyway, just to mix it up, there's some other pains that you can get. MS, atypical trigeminal neuralgia, deafferentation, dental pain, TMJ, etc. The initial management of someone with facial pain, particularly if it's in that shooting, is treatment with Tegretol. The first drugs used, does anyone know what the first drug used for trigeminal neuralgia was? It was phenytoin, and it was in about 1926. And that just changed the world. It wasn't until carbamazepine came about, which was, I think, in the 70s, something like that, that everyone found that that Tegretol was a bit better than phenytoin with few less side effects. And it's almost a tester. If someone gets a great response to Tegretol, it's a good sign, one, that they've probably got trigeminal neuralgia, and two, that they'll respond to other therapies, including surgical therapies. There are other medications, and I'll talk about them briefly in a really important thing to do is a dental review. It's extremely embarrassing to do a microvascular decompression on someone who then has root canals. It's usually the other way around, where people have had a lot of dental work only to find that it wasn't the dental problem. And we also arrange an MRI on everyone with persistent facial pain. Of course, you can work that out. You're trying to look for the secondary causes. Is there any evidence of MS? Is there a tumour within the trigeminal cave or anywhere in the intracranially? And we also these days look at the nerves themselves. And the current headache classifications are actually trying to divide things up even more, such that if you have a vessel touching the nerve as well as the classical symptoms, that selects a special group that do really well from early MVD, early surgery. So they're now separating that group off to say, hey, we should be operating on those people early. Yeah. Just to throw this up, does anyone know, do we have carbazepine here? No. In Australia, I learned all these new drugs. There's a new drug like tramadol out as well. That's just tepid. Yeah. I was learning all sorts of things in Australia yesterday. Don't give it to someone with trigeminal neuralgia. It doesn't work. So carbamazepine. There's just been a paper released that the secondary drugs, if you're not an anti-epileptic drug, the efficacy in quite a large study is nowhere near as good as the anti-epileptics. However, we tend to go carbamazepine, the neurologists like baclofen. Some people do respond to gabapentin. Lamotrigine has side effects, phenytoin has side effects. But sometimes it's worth, you end up trying anything and everything. And probably what's worse is opiates don't tend to work, but they do bomb, if you give enough, they do bomb people enough out that they forget about the pain. I thought this was I thought I'd put this up just to upset people. So this is one of the atypical facial pains that's just been published in a journal called Headache. And it's in the headache classification subcommittee group of atypical facial pain, which is persistent idiopathic facial pain, deep, poorly localized, typically unilateral, often in the nasolabial fold or side of the chin. Women in their 40s more common. 6% of people have already had a root canal. I sort of thought, I get a bit of that. The only thing is that the one treatment that they give for it is amitriptyline. So, surgical options, I shall leave in Mr. Schweder's hand.
To add to what Andrew said, most of the patients actually have already been to the dentist. Yes, if they haven't been, it's worthwhile going just to make sure. Many of the patients are referred actually from dentists or maxillofacial surgeons, and many have had plenty of surgery on the teeth. The most common cause, I guess you can divide treatment up into, all the medical stuff. Andrew's covered that nicely. And there's two things to think about. One is it may work really well, brilliant. It doesn't seem to last that long. So eventually one of two things happens. Either it becomes refractory. In other words, you have to increase the dose, which is fine whilst it works. Or the side effects become unacceptable. So you've got patients on Tegretol, you've got patients on gabapentin, and the side effects are, for some people, quite profound. Fatigue, they can't think straight, cognitive dysfunction in a sense, they can't focus or concentrate, problem for people when they're working. So if the side effects become unacceptable and or the pain breaks through and the medication is no longer effective, then one can think about surgery. Personally, what I feel is that it's worthwhile discussing that early, simply to give patients options. And you can run through a whole list of options. That doesn't mean they have to choose from a menu, but it's worthwhile them knowing there is stuff out there. And you can divide those options into something to treat the putative original cause, so this blood vessel that we'll talk about, and then something else to basically mess with the nerve or destroy the nerve. Those are then destructive procedures. They're more for backup. That wouldn't be the ideal first option. And these are options most well studied for typical trigeminal neuralgia, so what has lately been called type 1 trigeminal neuralgia, and all the other types of what has been broadly lumped as atypical facial pain, which you can then, if you're a geek like me, you can subdivide it in all sorts of categories like, type 2 trigeminal neuralgia, post-herpetic. All of those can respond to aspects of these surgical therapies, but generally, I guess the take-home statement is less well. So it can respond, but not as good as typical type 1. So we're going to do an MRI to double check if there's a weird cause, a tumor, or some MS. MS pain can still be treated. It's less effective doing some of these treatments, and often we have to think other treatments and even like neuromodulation kinds of treatments. But we get a fancy MRI, which basically looks for the cause, but it does miss it. It used to miss it 50% of the time. It would be 50-50 whether you see a blood vessel or not. Sometimes patients would worry, sort of saying, oh, there's no blood vessel, but they could still have one. The sensitivity and the specificity, they're increasing as MRIs get better and better. But the bottom line is, if you get an MRI report back saying there's no blood vessel, there could still be one. And there's still that concept of exploratory MVD. Ideally not, but it's still a possibility. This is an MVD. So this is one of the coolest procedures in medicine, obviously, in my opinion. But basically, there is a nerve and there's a blood vessel. It's a normal nerve. It's a normal blood vessel. You should have both, but they shouldn't be touching. That's the basic theory. There's all sorts of cool research about the demyelination that goes on. Something else happens centrally. Something happens with neuronal ignition and firing. There's an upset. The reason for all that fine print is that some people have this blood vessel without having pain. So if we scan everyone here, many of us who don't have pain will have a blood vessel there. So there's probably sort of a double hit hypothesis in terms of you have to have a blood vessel, ideally, and something else has happened. But the point is you have a nerve, you have a blood vessel, and they shouldn't be touching, often in a pulsatile way. It's mostly an artery, sometimes a vein. And the theory of an MVD is very simple. You go in there, you free up the nerve from the artery, and you put a little sponge in, a pillow. This is an endoscopic way. It's just a nicer picture. We can do it microscopic. That's an operation, though. So now we're talking, we have treatment with risk. And any surgery like this has risk, including serious risks, risk of dying, stroke, paralysis, hearing loss. They aren't very high, but they're still significant. So part of the process of, I guess, counseling patients is to mention this as an option, and then most of the time people think about it. They don't often want it right away. They want to think about it, maybe try a few other drugs first. To go back on the drugs, there has just been a meta-analysis of gabapentin and carbamazepine, which are in some ways equally effective, but once you've tried both of those and have maxed those out, most of the others won't work that well. It's a bit like epilepsy. Once you've tried 2 or 3 antiepileptics, your 5th, 6th, 7th, and your 13th, 14th, 15th antiepileptic is unlikely to give you much more benefit. So then you do think surgery. And also, if you add them together, if you're on amitriptyline, gabapentin, tegretol, and some lamotrigine, people will be drowsy, and chances are they're not working, and chances are quality of life is reduced. There's no doubt. In terms of looking at sort of a meta-analysis, this is one slide on the efficacy. So we can all remember the anecdotes. The anecdotes are that it can work immediately in the recovery room, they're pain-free, and they're pain-free for many years. That's great, but that doesn't happen to everyone. So it has a very high initial success rate. And for these, this is all the data for typical trigeminal neuralgia or type 1 or lancinating pain. It can be very effective even 5 years or even 10 or 20 years. But the efficacy in terms of percentage seems to drop off. That's not a gradual thing. It doesn't mean that somebody has 5 years of pain freedom and then gradually the pain returns. It's usually binarized. In other words, the pain suddenly comes back. But the percentage is that it'll happen in certain people. At that point, you can think other options or even repeat. But basically, it's a good option. It's not the only option, but it's an option that actually treats the cause. Because now that we've passed this part, everything else now is to do some damage to the nerve, which is less ideal than trying to treat the cause. Does that make sense so far? It used to be considered, most neurosurgery was considered a big operation. In a sense it is. It's an important part of the body, obviously. And it was, considered, is this only for younger patients? The typical scenario was somebody has trigeminal neuralgia, whether typical or not. The young people get an MVD. And the older we are, we do more destructive methods, which are more minimal and, however, a shorter term. But there's all sorts of analyses out there to show that actually this is an operation that can be tolerated by people as they get older. So we shouldn't exclude people in their 60s, 70s, or 80s. In fact, I'm certainly prepared to offer this operation. So is Andrew, and people who are older, as long as they're medically fit for an operation. It's about a 2-hour operation, about 5 nights in hospital usually. So this whole category of atypical facial pain, so if it's not type 1 lancinating pain, often type 2 or other variants, there's no blood vessel. So the question is, can we do something destructive to the nerve? And now there's so many options, and you certainly don't need to know them all. Know that there are some options there. Most of these options will make you numb in the face. So patients always ask, will I go paralyzed? No, because that's the 7th nerve, different nerve. But there is a near certainty of numbness, which for most people is more pleasant than pain. But it does affect some people because they often, they get numb. You saw Andrew's diagram about the inside of the mouth. If they're numb in V2 and V3 on the inside of the mouth, they often bite themselves as they're chewing. So some people have to alter their diet a bit, chew on the other side. It isn't that easy. It's something we counsel them through. But numbness has its consequences. Very occasionally, hopefully it doesn't happen too often, the cornea goes numb. That's more of a problem, and then people have to have regular eye checks and eye drops. In terms of messing with the nerve, one of my sort of favorite procedures in terms of ways to deal with the nerve or to destroy the nerve would be what's fancily called an internal neurolysis, which is basically either squeezing the nerve, putting a little hook in and stroking along the nerve, sometimes called poetically nerve combing or nerve stroking, but basically doing something to upset the nerve to make it go numb. It has some pretty good outcomes, but at 5 years you can see it's 50%. So in other words, it has an average shorter duration. So it wouldn't be your first choice. If you see a blood vessel, just deal with that. This is a backup option. You can certainly go back in a second time. Then there are percutaneous options, and you basically try to get to the nerve through the cheek. You put a needle in and do something to it. You can add a chemical like glycerol, you can add some heat like radiofrequency, or you can squeeze it with a balloon. You do something to destroy the nerve. We have a habit of doing balloons here. Andrew trained a lot in Bristol with glycerol. I train a lot with radiofrequency. There are all differing ways. They each have their unique advantages and disadvantages, but basically they're there to numb the nerve. And we're talking a few years of longevity. This does not last forever. So your 25-year-old, it's not ideal for, because you'd have to have multiple, and the efficacy reduces over time. I personally would think that a percutaneous option is better, either if they can't have an operation, because the percutaneous option is like a 30 to 40 minute procedure, or if the MVD has failed, or if it's not a true type 1 or type 2 trigeminal neuralgia. Do we want to be flooded in the sense with patients who have some sort of atypical facial pain? It's still worth discussing some of these options. You might want to try more drug trials, but it's still worth discussing because there are these destructive methods which work less. There are methods that work for post-herpetic neuralgia, like dorsal root entry zone lesioning with nucleus caudalis and fancy stuff to try and interrupt pathways, but they're less effective, and it is more of a challenge. I guess overall, the point of view would be the challenge is in the diagnosis. The obvious is obvious. Everything else is a matter of trying to figure out which type of pain it is and therefore what surgery to offer. One of them would be to cut the nerve, or at least part of the nerve, ideally not the V1 for the eye. And as Andrew said, it's hardly ever V1. It's actually much less common. If you have pain up here, chances are it's a different type of headache, one of the many other craniofacial pain syndromes. Or you can then section pathways, deal with the thalamus, that's a sensory relay station, the cingulate. You can do, in a sense, this is a branch of pain neurosurgery or functional neurosurgery, which most people never need. Or they can even have something like neuromodulation, deep brain stimulation, spinal cord stimulation, motor cortex stimulation. That's very rare. That's just the fine print, which the only time you tell patients is really to say, look, there are options if everything else fails. They may not be the best option because they have consequences having a permanent implant, a pacemaker, but they are options for later on. I guess in terms of overall recommendation is, look, the diagnosis, if we're trying to get back to the 1-minute neuro exam, for this, often isn't necessary. It's pretty obvious. Facial pain is facial pain, so they come in with pain in half the face. If they have something else weird going on, it's worthwhile, then thinking about a neurological exam. If it's simply severe facial pain, typical of, let's say, trigeminal neuralgia, the next step is really an MRI to look for some causes and then to look at options. And then the next step is to discuss treatment in terms of which medications to start.
But do measure facial sensation.
Yeah. Yeah.
Do check that one side.
Yeah. If there's true trigeminal neuralgia does not have an abnormality in facial sensation. In other words, if you have it, or if you have some weirdness or something else, if they're going, oh, I'm numb, I'm sometimes tingling, and then I have pain, and sometimes I also get tingling in my arm, chances are it's something else. But that's a bit of a red flag in the sense of one ought to look for other things. We're limited with time, so I was just going to move on to the acute onset of headache, which is much more straightforward to deal with. But do you want to ask any questions about trigeminal neuralgia? Not really. Not for type 1 trigeminal neuralgia, not even for type 2 in my practice. It can be effective for it can be effective for MS. So trigeminal neuralgia of type 1 or type 2 type with MS can respond to steroids, no doubt. Neurologists would prefer prednisone. We can give a course of dexamethasone, but the simple answer is no. You don't give steroids, do you?
Is there a reason why TCAs are not good for type 1s? Cyclic antidepressants?
There probably is a pharmacological or biochemical reason. Well, that would be the easy way to answer is I'm not sure. I'm not sure exactly why. I mean, it's been studied as to which ones are. It's probably related to the fact that we don't really know exactly the cause. We know from, one of my passions was in my research time was the neuroimaging of trigeminal neuralgia and pain syndromes. We know that the pain networks are altered with this kind of pain. So your brain connectivity is altered in this state of pain. So it's probably a lot more than just a blood vessel. But those altered networks, I'm not sure how to target with a single drug in a sense. Does that make sense? Yeah. Bruce asked to talk a little bit just about the acute onset of headache. I guess in a sense, I just thought, well, let's just talk about subarachnoid hemorrhage. Of course, you're going to see headache from other causes. You're going to see your acute migraine. You're probably, in fact, you're certainly much better at diagnosing that than we are because you see migraine and headaches all day, every day probably. But in terms of the, you do, don't you? There are actually, the fine print of all that, there are treatments, surgical treatment options for those, but hopefully those are hardly ever necessary. There have been trials in that, interesting trials with stimulation. I guess the concern that everyone learns at med school is subarachnoid hemorrhage. That's what everyone's concerned about because that's the one thing you don't want to miss. And there's, in a sense, 1 or 2 slides on this only. We'll go through some fine print as well. But if there is a sudden onset of headache, something that the patient's never had before in their life, it should be different. They shouldn't have this repeatedly. Then I think you're always safe to call an ambulance, send them to ED. No one would ever fault you for that. because you can't know. The next test is a CT scan, which you don't have. So no one would ever fault you if it's truly a sudden onset of headache, which something that the patient's never had before. Doesn't matter what the risk factors are, how old they are. It could be an aneurysmal subarachnoid hemorrhage. Good thing is if you send them in and there's a CT and it's normal, et cetera, well, then it wasn't. But you've done the safe thing. I think, there's one slide on it in a sense. I'll expand a little bit. The thing that we worry about in terms of subarachnoid hemorrhage is an aneurysmal subarachnoid hemorrhage. So if somebody says, in the medical history, they've had a subarachnoid hemorrhage, but they've had trauma, it might have been traumatic. The key thing is, was it an aneurysm? And if you have an aneurysm and you have a subarachnoid hemorrhage, there's degrees of severity. The one that we're talking about, the sudden onset of headache, that's the mildest version. The most severe version is it could be fatal. And everything else in between, differing degrees of stroke, coma. They're probably not going to present to your practice like that. You will probably just see the mildest version. Obviously, they're not going to present in a fatal scenario. But even in a stroke scenario, chances are they've already called the ambulance. They're already going to hospital. I've had a few GP colleagues. One of them's actually seen a subarachnoid hemorrhage in the clinic. I don't know whether you've seen that. You probably never want to see that. Have you ever seen that? No. Yes? It's pretty frightening. Yeah. So it's a spectrum. We're talking about the mildest version of the spectrum. The history is obvious. They're going to tell you about the headache, or the family will. There are some risk factors, but I guess let me go back to that previous slide where if you're worried, you send the patient in. You can examine the patient if you have time, but chances are you'll spend the time calling the ambulance to your GP rooms or asking your colleague to do that simply to bring the patient into hospital. Yes, they might have meningism, all the features of subarachnoid hemorrhage. Yes, they might have a neurologic deficit. They might have a third nerve palsy. They might have a degree of a stroke in terms of paralysis or weakness on one side. But the next step is go to hospital to do one of these, to do a CT scan. The one on the left is normal. The one on the right has some blood, so you can see here. This one has some blood. That's a classic subarachnoid hemorrhage. That's for us to diagnose, or specifically the emergency doctors to diagnose. And then they call us. The next step is we look for an aneurysm, and then it ought to be treated. Or an LP is done. Next step is treatment. In terms of looking for an aneurysm, we'll either do an angiogram or a CT angio. We don't have time to discuss this topic today, but in terms of incidental findings of an aneurysm, I certainly see plenty of that because I'm one of the vascular neurosurgeons. So we see plenty of that. Do you see a lot of that in the clinic? Are people worried and ask you about the risk of an aneurysm, when to scan and when not? I wonder whether that's a topic for another day. It's probably worthwhile discussing. I preempted it. This is probably what we'll spend 30 seconds on this. This is probably what they'll ask, could I have an aneurysm? Related often to a recent, something on stuff.co.nz or in the Herald, or somebody, has an extreme hemorrhage. So everyone's then worried because healthy people can have hemorrhages too. Or my relative had one. Is any of this relevant? Or they have an incidental finding. Yes, it's relevant. Yes, it's worth discussing. If it's an incidental finding of an aneurysm, or it hasn't even been found yet, none of that's urgent. So you can certainly reassure and, electively refer at some point. There's lots, we spend conferences and ages talking about what we can do in terms of ways to treat, when to treat, doing risk calculations. And, for a geek like me, doing all those calculations is fascinating and interesting. But the two things that we know of that are lifestyle modifications that you can start with a patient that can drastically reduce the chance of something rupturing, if they have an aneurysm, would be to stop smoking and to manage hypertension. That's what I always tell patients, ideally to stop. Of course, it's much harder than just saying it. And the other is to monitor for hypertension, and if there's hypertension, to treat it. So you can that reduces the risk so much more than probably even fixing an aneurysm or any other factor. In other words, you can do so much more probably for an incidental aneurysm than any one of us ever could. We can treat it, but treatment has risk. Stopping smoking has no other risk, and treating hypertension probably doesn't have much other risk, I assume. You treat hypertension every day. That's it on headache. So I guess the conclusion there is, if there's a concerning feature of a sudden onset of headache, something that the patient has never had before, it is worthwhile referring to the emergency department. That's probably what you've been doing anyway. Is there a question about that?
You do quite often get people saying, my relative had one. Is that relevant to them? Is there any family?
Two aspects to that. It's very relevant to them if they've actually seen their family member have a subarachnoid hemorrhage and either suffer from it in some way or die. Then they've seen the worst sort of potential outcome. It's relevant to us if there's 2 first-degree family members. So there's a familial aneurysm study that demonstrated 2 first-degree family members. In other words, mother and father or parent and sibling. But anything else like, I've got 2 uncles or 2 aunts, it actually is statistically to us not that relevant. If it is really relevant to the patient and they're really worried, it doesn't hurt to scan. They just have to be prepared for the finding. It might find either an aneurysm, the obvious statement, right? Or another incidental finding, like a pituitary tumor, which Andrew treats, or like a meningioma or something else that they didn't want to know about. So we always counsel them, I certainly always counsel them first, is be expected that we could find something else. Does that make sense? Should we go into the quick neuro exam? I shouldn't say it takes 1 minute. Maybe it takes 1 minute. And I don't want Andrew to scold me saying, why are you talking about this 1 minute neuro exam? I guess the reason why the catchphrase is 1 minute and can it be quick is you truly have the luxury of just targeting towards the symptoms. And we all know that you don't have time. You've got like a 10-minute consultation, 5 minutes to write up. If that, you might have a 5-minute consultation, 2 minutes to write up. Everyone's pushed for time. And I think this leads into sort of a bit of the brain tumor talk and a cancer talk. If somebody has brain symptoms, then a quick targeted examination towards that. And if somebody has spine symptoms, then a quick targeted examination towards that. All the other stuff, if you do every single aspect of Telly O'Connor, of course it's going to take you way too long. And look, I don't do that. I must admit, I'm not sure if Andrew does that. Maybe a neurologist would do all of that, but none of us have the time to do it. And the things you don't want to miss are things for the spine like a motor deficit or a myelopathy, and things in the brain like some obvious concerning symptom like blindness or visual loss. But most of that is going to be mentioned in the history. And this relates a little bit to cancer and neurosurgery in terms of brain or spine metastasis. You'll certainly see this. There's an increased number of those. As treatment for systemic cancer gets better and better and better, the brain is still immune to a lot of the chemotherapy, and cancer still goes to the spine. Andrew's got some slides on brain tumor, so because we didn't collate the slides, I'll just skip through these and go to the neuro exam. So if we talk about the brain, if you've got a lump in the head, it can cause raised intracranial pressure. It's probably not going to be severe pressure when you see them in clinic because that would induce a coma, some reduction of GCS, or even it could be fatal. Chances are that won't be in your clinic. But they might have symptoms from something pushing on certain parts of the brain, and it's related to tumor location. So if you want to be comprehensive, you can do all of Telly and O'Connor, but chances are they'll have a problem related to this. And no, we don't do fundoscopy regularly, so no, you don't need to do fundoscopy. In fact, I don't know, you probably have fundoscopes for all the ophthalmic things, eh? You can use it if you want, but I don't think it's valuable in brain tumor. Do you use it? Yeah. Okay. Andrew's actually got one. The quick neuro exam would be a GCS, and chances are if the patient is talking to you, they're orientated, they're GCS 15. That's done, easy. The main cranial nerves, the ones that are obvious, and they'll tell you, oh, look, I've got hearing loss. You had a talk about hearing loss from Michelle Neef. They'll tell you. So chances of picking up hearing loss on a cranial nerve examination in the absence of actually complaining of hearing loss is actually really low. They've done studies on that too. A sensory finding on the examination, you're not very likely to pick something up if they also don't have something sensory in the history, which stands to reason. And then the limbs, upper and lower limbs, and gait.
Okay, so this is a quick neuro exam. So I try and think of ways to make it so that I can pick up everything I'm wanting to pick. Then you can focus down on what you're doing. So in my head, I've looked at things like, you know about SCAT5 and SCAT3 and SCAT4? You looked at that? If you haven't, get it. Pull it down off the internet. It's free. It's a rugby concussion orientated neurological exam, okay? Read it. It's people trying to make things fast, okay? And that's what the medic questions on the side, because we want to get them back on the rugby field, but people have actually put a bit of time into working out how to do this slickly, So I really like that SCAT 5. It's 5 now. Is it? It hasn't. Okay. So, but the things that you start off with are higher functions. Alert, interactive, orient. Can they talk to you? Do they know where they are? Speech, if you're going to assess speech, naming, repetition, comprehension, reading and writing. I don't do that to everyone. But I find asking someone to do, say, round the ragged rocks. No. Round the rugged rocks, the ragged rascal ran. Is actually really quite good at attention, concentration, repetition. Okay. Serial 3s. I do serial 3s because I can't do serial 7s. My maths is not very good. 3 paired objects. You know, I've got the same 3 paired objects that I've been asking for 20-something years now. I remember them because I ask them all the time, and I'm relying on the fact that they haven't come back and seen me. Mini mental state's quite a good assessment. And if you say, send me a letter, this person's failed a mini mental state, and you can get your nurse involved in doing that. And that's a good way of communicating an overall mental state review. And there's all sorts of new ones now. GCS, Glasgow Coma Score, is a score designed to pass information about how unconscious you are. And it's a very generous score. You get 3 when you're dead, okay? And but there's big sections, aren't there? If you're a 15, you're in pretty good nick. If you're not great, you're a 14 or a 13. 12 means you're sliding down the slope. 7 means you need to be intubated. 3, 4, and 5, you're pretty trashed, okay? And that's how I think about them. However, if I'm ringing you and telling you I need to be able to communicate each step, just saying a number, a GCS of 13, tell me what that is, because it gives me a way. If you've got if your eyes are opening or you're talking, but your motor score is a 1, I'm going to suspect there's something wrong with the most important one, of course, is the motor score. That has the greatest prognostic indication. But in general practice, you're going to really be dealing with 15s, 14s, and it doesn't mean much. So, what do I do? My quick exam. Can I get you to do something for me? Okay. So my motor assessment's quick. Can you walk up on your tiptoes? So you're looking at S1, walk up your heels. Okay, can I get you to do a tandem walk? Can I get you to do one foot in front of the other? Can I get you to stand on one foot? Can I get you to stand on the tiptoes of one foot?
Sure.
Yeah. Try this at home. It's actually really good test of coordination, motor function of all your leg motor function. So if you can get a patient who can stand on a tiptoe of one foot, I don't do anything else. Romberg sign's quite good for, you get some truncal balance, looks at proprioception. That's really quick, Romberg sign, eyes closed, palms up. Upper limb, I do wings, pull, push, the usual. The one that people often forget to do is policeman stop sign and bra strap. Because it's the one thing to me that differentiates between rotator cuff and shoulder issues and a C5 radiculopathy. Policeman stop sign, bra strap. Don't forget it. Lower limb we've talked about. Reflexes are quite good. And I've got a big long tendon hammer and people get scared as I bring it out. I think I bring it out just to upset people. And half the people haven't got it's useful if they're brisk and they're spastic. The 2 tests that I find the best are planters, but you do have to take the socks off. And Hoffman sign is useful. We all know what Hoffman sign is? Hoffman sign's a great little sign for picking. Unfortunately, if you're nervous, your Hoffman sign's positive. Hoffman sign, and middle finger, and you flick it. And the thumb flexes when you're stressed. Okay, so hand, you flick the middle finger, and the thumb will flex.
You can't do it on yourself. We should see all those who are positive.
Yeah. Okay, and the last little thing is cranial nerves. Okay, so you can't do this in 1 minute. Okay, but if you're wanting a really quick way of doing a cranial nerve assessment, this is it. Smell. Coffee's okay. Lemon, cloves, can they smell? Epi-Path. Acuity, fields, eye movements, pupils, accommodation, fundi. Why? Because you don't shine the light in until the end. And by doing it in that order, you don't ruin the rest of the test. Okay? So Epi-Path. Acuity, I use a near chart because I'm lazy and my room's not very big. Fields to confrontation. Eye movements, sideways, up, down. Look at both eyes. Pupils with a torch. I don't do accommodation. I do sometimes when I remember. And I do pull out my ophthalmoscope and I do look at the fundi. And I believe that I can see venous pulsations. Okay? And then I've got some cotton wool, fluff, 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 fluff. Grimace, screw up your face, show me your teeth. That's my 7. Hair crackle, gag, tongue protrude, shoulder shrug. That's your cranial nerves.
I guess we all develop over time our sort of ways of cutting corners and trying to make things slick and quick. I don't regularly take out the fundoscope, but I think the main thing is a motor problem. So GCS, yes, we've gone through. I mean, the cranial nerve examination, you can do that pretty quickly. I pretty much do it very similar to Andrew, but cut a few corners in terms of hearing, because just the chance of picking something up is much reduced. But then when it comes to the limbs, let's say you don't have a brain issue, you're suspecting someone with neck pain or with back pain, you can focus your neuro exam. Of course, they're going to be GCS 15 because they've just told you an eloquent and accurate history of what they've got, or maybe less eloquent, but they've told you about what they've got. And then you can focus on the upper limbs and the lower limbs. And if it's a lumbar spine problem, well, then you can focus on the lower limbs. You've got the luxury of calling the patient back, of course. I'll see you in 2 weeks, et cetera, to see if there's any change. But if the main red flags or the main things to pick up on are really a motor deficit. The chance of finding, let's say you do sensation. Of course you can do it. It can be very easy and quick to quickly check light touch in each dermatome. Yes, it can be easy, but the chance of finding something in the absence of the patient actually complaining of that is actually much less likely. The main thing would be motor power. And reflexes, yes. The planters, sure. But an isolated reduced reflex or an isolated brisk reflex doesn't really tell you much in the absence of, again, some motor sign. In other words, we don't really operate on an abnormal reflex. So if somebody says, triceps is missing, do we operate because of that? Well, not really. You can refer the patient based on that. Chances are it may not even be that urgent, but we'll try and piece it all together to see if there's for example, a C7 myotome issue. So when it comes to the when it comes to the spine, a version of a motor examination would be in terms of the spine. Yes, the neck, you can check the range of motion. It's going to be obvious because they'll have a stiff neck if they've got neck pain. You can check tone, and a Hoffman's is a quick examination of a reflex that relates to tone and spasticity. And then you do each myotome, just like Andrew said, up, this one, and all the numbers, There's a bit of overlap, but 5, 6, 7. So those are the most common ones to look for. Do you have to test the reflexes? No, you don't have to, because again, if you find that they can move their arms fine, they've simply got pain in the neck and or pain in the arm. In other words, there's a problem, but if they can move their arms okay, chances are you're not going to pick up anything with testing the reflexes. And yes, you can test Hoffman's. I always do. Just to add, or to complete the examination, and it's the same for the plantar. So with the cervical spine, there's 2 aspects. You want to test the arms And then you want to test the lower limbs to see if there's any real issue relating to the cervical spine. In other words, cord compression. In other words, is there a myelopathy? And the things to test for is tone. That would be clonus. That's pretty quick to do. The reflexes, yes, sure. A plantar, although if you have an isolated upgoing plantar, again, that's not a reason to rush into an operation. It might just sort of add to the picture. It's not the entirety of the picture. And see how they walk. So yes, you can do the S1 and the L5, but also see if they walk myelopathically. And you've probably all seen a myelopathic gait. Have you all seen a myelopathic gait? Like stiff sort of gait with spasticity in the legs. Once you've seen it once, or if you just look it up on YouTube or Google videos, what a myelopathic gait looks like, you'll never forget it. It's a pretty obvious gait. And so half the examination's done when it comes to the cervical spine with the patient walking into the room. Adds to the mix. And yes, no, you don't have to feel forced to do light touch. If they say, look, I'm numb here, well, then you can isolate it and double check if it's numb here and there's the other areas of numbness. But if they've got no numbness anywhere, you don't have to, feel like you have to complete it. We always do, but we have the luxury of more time. I give patients see me for a whole hour, so then of course we have more time. But I know that you don't. And the whole purpose that Bruce said is, he said the bottom line is you don't have time. I'm assuming that's the case, eh? Yeah. Same with the spine. Everyone in med school talks about what about the sphincters. I mean, the sphincters, a lot of that's in the history. If they've had episodes of incontinence, urinary or fecal incontinence. So in other words, for example, for neck pain or for back pain, in terms of considering something, the neurological exam just determines the urgency. If they've got pain down a leg, whether it be from cancer compression, whether it be from degenerative compression, or pain down the arm, yes, that's important. Yes, you can manage it with pain relief, but if you want to investigate it further, the only thing that determines the urgency is the quality of the neuro exam. In other words, if they've got pain down the arm and they've got a paralyzed C7 and they can't move it, well, it's probably a bit more urgent. Or if they've got pain down the leg and they have a foot drop, well, then it's probably a bit more urgent. But in the absence of a motor concern, in a sense, it's not actually that urgent. So that's where it's helpful. So your quick screening exam is simply, how urgent is this? Do we need to do something? Do you need to make a phone call this week or even today? Does that make sense? If you have the luxury of time, you can do all the rest of the neuro exam as well. And I guess one conclusion would be most major deficits are obvious, and either the patient's already reported them or the family of the patient has reported them. It's slightly different with neurological, not neurosurgical, but neurological exams like cognition and Alzheimer's screening, dementia screening, which neither Andrew or I are experts at. But if you do like a mini-mental state or a MOCA and all those kind of things, that of course takes more time. And you probably don't do those on a regular basis, do you? Do you do MOCAs in the clinic? Oh, okay, sorry. Okay. Well, how long does a MOCA take? A bit longer. Maybe there's a way to speed it up, and your urologist might be able to help you. Yeah. So there's two types of tumors. There's the primary ones from within the brain, which Andrew will mention, and the latest molecular markers. And then there's secondaries. In other words, anything that goes to the brain from any other cancer. I'll talk about that afterwards then.
Okay. How do we get it? So I just wanted to mention some things about brain tumours and what's changed. Okay. So this is not going to tell you anything about brain tumours or how you pick them up and what they mean. It's where the world has changed in the last 5 years and how we need to change our thinking about them. Now, brain, it's not rocket science. And neurosurgeons are simple people. There is a World Health Organization classification for CNS tumours, and it goes from 1 to 4. It's because we don't do maths great. If it's a 1, it's a good tumour. And if it's a 4, it's a bad tumour. If it's a 2 or a 3, it's probably going to become a bad tumour. That's as difficult as it is. Grade 1s and 2s tend to be the things that are like meningiomas, growth from the coverings of the brain, schwannomas, which come from nerves, or neurofibromas from nerves, pituitary adenomas that come from pituitaries, pilocytic astrocytomas, particularly that you have in kids. That's what you want. You want one of those, but you want it in a nice location. And with benign or lower grade tumours, the determinant on outcome is where it is. So if it's on the top of your head, piece of cake. As a neurosurgeon, if you refer that to me, I think, fantastic, I'm not going to kill someone today. You know, I'm unlikely to wreck this person. Whereas on the base of the skull, it's in amongst the stuff that's important. So even nice tumours can be bloody difficult. Astrocytomas or glial neoplasms, different game. What's the presentation? Everything. You know, I've had people coming in complaining of all sorts of things. Headache, vague neurological complaints, loss of sexual activity, you know, hairs falling out. I don't know how. I'm lucky. I get it after you guys have seen the patient and sorted it out, because I couldn't do it. You know, I can go, needs a scan. And one of the things, see, I'm lucky, and I can say, no one should leave a neurosurgeon's office without a form for a scan. And we're in a bad situation in this country in the fact that our MRs are about $1,800 to $2,000. If you go to Australia, they're about $600. So we get bad, and I don't know why. And the access for GPs in Australia can order CTs, and in some areas can order MRIs as well. And in some aspects, that means there's maybe some extra scans are done. On the other aspect, we get big tumours here because they get diagnosed late. Anyway, the bad thing about MRI scans is that they find stuff. And pineal cysts, if I scanned everyone in this room here, I would find quite a few. If I asked how many people in this room had headaches, I would find quite a few. If you drew a Venn diagram, you would find there would be an interaction. And so some people come with pineal cysts and headaches and want their pineal cyst removed. And unfortunately, we have colleagues in Australia that offer the surgery for that. And the placebo effect is strong. Chiari malformations also are common, and we pick them up far more commonly. And so Chiaris are only a really problem if there's an associated syrinx, cyst within the spinal cord, or they really have the classic cough, headache, and sometimes some dysmetria of vision. But a lot of people got Chiari malformation. So what's changing in tumours? The way we look at tumours has changed. What used to be a grade 1 or a grade 2 or a grade 3 isn't a grade 1 or a grade 2. So you can forget about any analysis that we've ever done in the past about what was this type of tumour or other, because it's all wrong. Okay? So what we do now is we actually look at the genes in the tumours, and then we don't do it in New Zealand, but if we've got a difficult tumour, we send it to Germany, and they do this molecular array, and they put it up on this big flash chart, and there's sections that are bad tumours and good tumours and this type. And that's how they're now identifying what things are, rather than on a structural basis, on a light microscopy basis. And so that means we're going to actually get the correct diagnosis, plus we're going to identify genes that can be targeted. So the ones that jump out. So if you're going to have a primary brain tumour that's more than grade 1, you go for an oligodendroglioma, and you ask for it to be 1p19q deleted, okay? Because that's a dramatic difference in your outcome. People live 10 years. They're the people who survive a long time. Probably everyone's too. Anyone remember Roxette? The lead singer of Roxette? She's still alive after a primary brain tumour. What did she have? Oligodendroglioma. Okay. So we now can pick them because we get the pathology. Astrocytomas. For years you've read reports coming from us, we've chopped this tumour out and it was MGMT, EGFR, QRFZ positive. And unfortunately, despite all our smartness, it's come back to one marker, means all the difference, is IDH1. And if I think it's quite, I don't know why this is, but if you're wild, it's bad. But if you're mutant, it's good. So you want to be a mutant IDH1. And sadly, it makes a huge difference. So a grade 2 astrocytoma that is IDH1 wild has almost the same prognosis as a grade 4 glioblastoma multiform. And so you can take this relatively benign looking tumour out of someone, get the pathology, it looks really good, it's going to come back despite whatever we do. And that's a terrible thing it's very hard to tell someone that looks really good, but you're in the worst prognostic group. Then there's other things like MGMT, which means you can use temozolomide, which is a drug that adds about a month. Surgery, we've gone backwards in time where they've moved away from surgery and now we've come back again where you maximise tumour volume reduction. And you reduce the mass effect and you stop people coning and dying and you try and take as much tumour. What is acceptable harm? And the thing is, people decide for themselves what acceptable harm is. And in the past, as surgeons, we've been going, oh no, we shouldn't operate on that, that's bad. And I don't know whether it's because society's changed, religion's changed, but people want to live, and people are prepared to live with a deficit, and people are a little bit scared to die. And saying that you're not going to offer any treatment for someone because you might hurt them a little bit is no longer acceptable. And so you have to be careful about selling hope as opposed to being nihilistic. And it's the individual's right, as long as they understand, to choose. And so for you guys, they come and see me, then I send them back to you. And the reason being is that I want normal opinions. I want the family's opinion. I want your opinion. I want, so that we can make a decision together, because sometimes you hurt people with the purpose of trying to get them to have that extra 3 months so that they can be with their grandkids or with their family. The other role is trying to maintain that existence, repeat surgery for high-grade gliomas, each time with a hit. Repeat radiation therapy produces radiation necrosis, but people do live longer. You're buying years in some people with stuff that they'd normally have died within 12 to 15 months of the whole thing. Oh, that's all right. And repurposing drugs, people are taking metformin and all sorts of stuff for GBMs. Who don't know whether it works, but sometimes that concept of hope, of trying something is worth it. Melanoma in breast. Now, this is the one thing that's probably changed, and I think Patrick's going to continue, is that with the new, NIBs, are they NIBs or IPs? I can't remember the drugs. IBs and AD. The new drugs you give for melanomas, it's just changed the world, really, because melanoma, you can't die with it now. Oh, no. And the fact that the systemic disease is controlled on people that would normally die, and now we've got to deal with the cerebral metastases because it doesn't control the intracranial stuff as well, blood-brain barrier and all. So we're getting to see a lot more cerebral metastases and taking them out, and people are surviving fantastic lengths of time. Well, the game's changed. As long as we can include lung and other things, it'll be great for people. But at the moment, breasts, melanoma. So we can take up to 3 lesions away, ideally during one sitting. And I love my melanoma patients because they want to live. They've been through the trials of having a diagnosis of cancer, of thinking they're dying, and I get people, and my favourite patient had 3 cerebellum metastases taken out of her cerebellum. That was on a Wednesday, and she went to the Cher concert on the Friday night and sent me a text saying...
I think Andrew's covered that primary brain tumour stuff really nicely. It is all about that last line of the report saying, is this IDH1 mutant or wild. That's all it's about now. And we'll probably report that back in the clinic letter anyway. That's the main change. The main change with brain metastases is, what hasn't changed is that we've always had a blood-brain barrier, and it's always, in a sense, made it difficult for drugs to get across, including all these cool new chemo drugs. So as chemo gets better and better and better for all the systemic disease, for breast, for lung, for melanoma, especially for breast and melanoma, stuff still goes to the brain. And unfortunately, not all of this drug stuff goes to the brain. In other words, you can still get metastases even years and years later. But that does give us the opportunity that if we treat those metastases effectively, you can still contribute to local control, what we would see as local brain control, but overall increased survival and increased a better quality of life. So if your patient, I guess in terms of seeing someone in the clinic, you've all got, we can't escape the cancer patient, we've all got cancer patients. If your patient has any kind of cancer, strictly speaking, any kind of cancer can go to the brain. There are some that are much more common, breast, lung, melanoma, kidney, but any cancer can go to the brain. So the first part is, yes, it can go to the brain, and is the therapy effective for the brain? Chances are it may not be, although there is better and better research with stuff that is able to cross the blood-brain barrier. Even the things that we're doing at the Center for Brain Research in terms of trying to couple drugs with other things that go across the blood-brain barrier. But basically, if you have a cancer patient and they now have a headache or a concerning neurological symptom or sign, and you do a quick screen and something's wrong, the vision or something obvious, chances are they would need a scan. And like Andrew said, at the end of our consultations, first of all, we have the luxury of time. And the second is we always finish up with a scan saying, okay, let's get a scan, whether it be CT or MRI. You don't have that luxury, but I think in having said all of this about the neuro exam, if the patient has a background of cancer, it's always worthwhile being more concerned because cancer can always go to the brain and the spine for that matter. And there's all these beautiful sort of provocative, 2 minutes. Okay, I'll do it in 2 minutes. There's, articles written, about breast cancer, brain metastases, the last frontier, all these reviews about this is the part that hasn't been dealt with breast cancer. Or melanoma, you can see exactly the same in the melanoma literature, in the renal cell carcinoma literature, in lung cancer literature. Yes, it's a frequent issue. Yes, we'll always see more. There should be, in terms of statistics, there's probably about 200 people every year in Auckland who have a new diagnosis of a brain metastasis. That doesn't mean they all need treatment, but they have that diagnosis. Sometimes solitary, sometimes multiple. We usually discuss these in our MDM anyway, so our multidisciplinary meeting at Auckland Hospital, we usually discuss the scenario and then sort of see what's best for the patient. Often what we're missing, though, is the information, what would they actually like? What would they like? We see them in the clinic anyway to discuss that, but what has the family thought about? And are they in good shape? In other words, are they fit and healthy? Do they want to battle on? Are they ready for an anesthetic? And if not, could we do radiotherapy? But for all these reasons that I've just mentioned, the blood-brain barrier, the longer survival, brain mets continue to be a problem that you will see and consequently will see. And we'll find better methods to treat it. But we sort of base current treatment on the American Association of Neurosurgeons guidelines and the CNS. So AANS and CNS are sort of the biggest two societies that we go to their meetings and we follow a lot of their guidelines. North American guidelines, but they're still applicable here. So the question is, when you have a metastasis, we've got 1 minute now, hey? How many is too many? A solitary metastasis is obvious. That's worthwhile taking out. Multiple metastases, the general teaching is 2 or 3, maybe all of them to be taken out, followed by radiotherapy. Or if you have multiple, let's say 6 or 7, then sometimes it's worthwhile taking out the symptomatic one. If one is producing a weak arm and edema is going into the motor cortex of the arm, it is worthwhile treating that one and following the others with radiotherapy. So the conclusion is the mainstay of therapy is this, and there's good class 1 evidence, is surgery followed by radiotherapy. And the various permutations of what surgery and when and what kind of radiotherapy, that can be discussed to the hilt. There's meetings on that. But basically, I think the conclusion of this, of brain metastases, is if you have a patient who has cancer and they have a neurological symptom, it's worthwhile referring them for a scan if you can. And the way to treat that is with surgery followed by radiotherapy. And then you can do the whole, translate all that to the spine, and it's exactly the same. Does that make sense? I think we've totally run out of time. I think we've way run over, actually. Anyway, are there any questions about that, or any of this, actually?
For an acute stroke, if you see within the first 1 hour, is there a likelihood that in the near future we'll have acute interventional radiology?
So there is acute, depends where you are. In Auckland, there is acute intervention for an acute stroke. So the disclosure is We're not involved in that. That's a neurology service being provided with the interventional radiologists. But there is an acute service where if you have a stroke, you get evaluated then for whether clot retrieval is worthwhile. So that's the intervention, is an endovascular procedure for clot retrieval or thrombolysis and all the other stroke treatment, blood pressure management, etc., rehab. But if you're asking about clot retrieval, yes, it's available. And yes, if you pick it up early, you should send them into ED rapidly for consideration of clot retrieval. But I think it's only available in Auckland. And if you're rurally, I'm not sure. I don't think it's available in Hamilton, for example. I mean, is everyone, not everyone's from Auckland, I assume? No. Oh, you are? Okay. Well, if you're from Auckland, then the Auckland Regional Stroke Service has that service. Yeah. Waikato doesn't. It has. Okay, sorry. Maybe it's new.